Yes, so good morning and welcome to everyone who's joining us today. This is a series of webinars that probono.org has been hosting. And today we're going to be talking about access to healthcare services by persons living with HIV/AIDS. This is the fourth webinar that probono.org has had. And today we have two experts in the field of access to healthcare services. That's Professor Naima Abrams from the South African Medical Research Council and Sasha Stevenson from the renowned Section 27 Civil Society Organization. And also today we're going to be taking the opportunity to launch probono.org's resource manual, which we hope that all legal practitioners who have an interest in HIV/AIDS will be using in order to further their work. So without further ado, I'm going to hand over to Teresa, who will be giving an overview of the work of probono.org in this project, as well as the other initiatives. Teresa.
Good morning, everyone, and thank you for taking time out of what I know are busy schedules during this time to join us today. As probono.org, we are very happy to have two very esteemed presenters today to look at how people who are affected by HIV and AIDS and TB are able to access healthcare in South Africa. This webinar, as Chantal has said, is the fourth in a series that Pro Bono has been hosting, which is focusing on broadly issues around diminishing the discrimination and stigma related to people who live with HIV and TB. We are decades into the HIV and AIDS pandemic, and we have lived for centuries with tuberculosis and within our communities in South Africa. Yet, and still, people still struggle to access their basic needs and rights under the Constitution since 1994. So, probono.org has been working with a generous grant from the AIDS Foundation of South Africa to look at ways in which we can firstly broaden people's understanding around the issues related to key and vulnerable populations in South Africa. And secondly, to look at how we can create strategies to really, in the long term, eliminate discrimination and stigma related to people's status. So we know that healthcare, access to healthcare, is a critical part of this work. That if you can't access healthcare, or if you don't get the respect that you should get when you go into any government or private clinic or hospital, when you are a member of a key and vulnerable population, that impacts your willingness to seek the care that you need, and impacts on the health of, on your life, your health, your family's life, and other issues. So without further ado, we would like to just thank our panelists and get into this important discussion. So thank you.
Thanks, Teresa.
So our first speaker for today is Sasha Stevenson, Section 27. Sasha has a very impressive CV. She studied at Rhodes University and the University of Cambridge, and she is the head of the health department at Section 27. And Sasha will be sharing with us today the latest work by Section 27 in respect of access to healthcare. This organization has been at the cutting edge of furthering the right to health in this country. So if I can hand over to you, Sasha.
Thanks, Chantal, and thank you so much to Pro Bono for the invitation to be here and talk about some of our work today. I'm just starting the slide here. There we go. So I've been asked to talk about some of Section 27's work in the last while, and I've picked kind of the last 10 years or so to talk about our work on access to healthcare services by people living with HIV. And I think before we go into the details of that, it's important to recognize the context of our health system, which many of us know, but I think is easy to forget and to skip over, because that context is so determinative of people's experience of accessing healthcare services, both people living with HIV and the rest of the people in the country. And so to start off with, we know that there's a massive disparity in funding between the public and the private sectors. And that disparity is so dramatic that about half of the money that gets spent on health is spent in the private sector that serves about 16% of the population. And every year, fewer and fewer people are within the private sector because it gets more and more expensive every year. So every year, more people are becoming what's termed uninsured and dropping into the public healthcare system, which operates with half of the budget, half of the total health spending in the country. So we have a real resource constraint within the public healthcare system. And linked to that and also other things, we have a real quality problem. So the Office of Health Standards Compliance does surveys or audits of health facilities. And the last audit they did, they audited 730 facilities around the country and found that 9 of them met the national core standards for healthcare facilities. That's actually worse than the time before when they assessed healthcare facilities. Not all of the health facilities in the country, but they were taking a sample, and it shows the real significant problems in access to quality healthcare services. Then we look at maternal mortality rates, and we find that while they have been decreasing, and that's important to recognize that they have been decreasing, still in 2016, which is the last time data is available, 5 of every 1,000 pregnant women died during or up to 2 months after childbirth. So we still have relatively high maternal mortality rates. We continue to have stockouts of medication throughout the country, including antiretroviral medication, TB, childhood vaccines, all sorts of medication. And in some places, for example, in the Eastern Cape, there's up to 60% vacancy rates in hospitals. And so we've got a real human resource crisis, as well as the financial resource crisis, the lack of medicines, and the poor quality that people are experiencing. So that really is the context of our healthcare system in which people living with HIV and others are trying to access healthcare services. I think the next thing to say is to recognize that the vast majority of work in increasing access for people living with HIV to healthcare services is done by activists on the ground across the country. It's usually done without any fanfare, without any media. It's done at clinic and district level with people chatting to heads of facilities, negotiating for access to medicines, having sit-ins of a few people within a facility or a district office. This isn't big bang stuff. It doesn't hit the newspapers, but it's the vast, vast, vast majority of work that's done to increase access to healthcare services across the country. And that's done by people like the Treatment Action Campaign and other organizations and individuals who work tirelessly across the country. So at Section 27, we do work that's focused on increasing access to services and decreasing discrimination for people living with HIV, but we also look at the system more broadly, because obviously that affects PL-HIV and it also affects everyone else. And we think that you can't see access to particular services outside of the context that I described at the beginning of this. So we do a lot of work on health system reform, including in relation to national health insurance, trying to make sure that any health system reform actually increases healthcare service access, rather than just shifting shifting the chairs on the deck of the Titanic, which is what some of health system reform can look like. So we try and make sure that health system reform is properly informed by people who are accessing and providing healthcare services, and that it in fact increases access to services. We also do work on funding for health and HIV. We know that in particular in this last budget, the budget for health services has decreased when you take COVID out of the equation. There's really been a shifting of money from other health services and from education and social grants and other important places towards COVID and out of HIV services and others. So we monitor and do advocacy around that work. We do a lot of work on access to medicines, and that's at the intellectual property level, so making sure that there aren't barriers because of monopolies over medicines to access those medicines, but also at a local level, and I'll talk a bit about the Stop Stockouts project in a bit. And then we do a lot of work within AIDS councils at national, provincial and local level, working with other activists in these AIDS councils, providing some kind of support, providing training where it's needed, and participating in the activism at that level. So some of our cases on HIV of the last few years are coming up now. In 2012, we worked, there was a crisis in the Mthatha depot. You can see that's the part of the Eastern Cape that it serves. It's about 100,000 people who receive medicine through the Mthatha depot, which is where all the drugs come and then get distributed to health facilities. And at that point, 53% of facilities didn't have antiretroviral treatment. So there were huge problems at the Mthatha depot. Part of the problem was that there was no depot manager and there was massive understaffing at the depot, but there were also big corruption problems. Half of the depot had been burnt down in order to cover up some corruption not long before that, and it was just generally a complete disaster zone. It was coming up to December. People usually get extra medication, extra ARVs in December so that it sees them through when they go home, and they weren't able to get any, they weren't able to get their antiretrovirals. And so we initiated litigation with the Treatment Action Campaign and people within health facilities in the Eastern Cape to seek an order to reform the Mthatha depot and ensure access to medicines. And in the end, what happened is, rather than litigate, the Eastern Cape allowed MSF and the Treatment Action Campaign to go into Mthatha depot and essentially to overhaul it and run it for a couple of months. And they really turned the place around. They managed to put in place systems that unfortunately didn't last forever, but did last for a number of years, to improve the way that medicines are received into the depot and then distributed, and then to increase access to medicines throughout that big area of the Eastern Cape. So that was one of the early pieces of work that we did relating to, or not early pieces of work, but one of the pieces of work that we've done relating to access to medicines and to art in particular. And it led to the development of the Stop Stockouts project, which is a project that is co-organized by TAC and us and MSF and the HIV Clinician Society and Rural Health Advocacy Project and Rural Doctors Association of South Africa, to allow for the monitoring and reporting of stockouts. And it's incredibly important because the stockouts, as I say, are continuing, and often the government doesn't really know what's happening, and they'll only find out when it goes to the media. And so this is a way for stockout reports to be escalated through the proper channels from local all the way to national level to ensure resolution of those stockouts. And then there's an annual survey that gets done to assess the level of medicines availability throughout the country. So it was something that started with litigation, moved towards a physical intervention, and has ended up as a project that is ongoing and that monitors availability of medicines. Another area of work that we were involved in was related to the Sikisiki Village Clinic. The clinic had been an MSF ARV site until 2003. It was the MSF had worked on an ARV utilization essentially in Khayelitsha, and then wanted to test the ARV program in a place with a bad healthcare system. And so they went to Sikisiki and they operated out of Village Clinic for a number of years. And then in 2006, the facility was handed over to the Eastern Cape Department of Health to run as a normal clinic. The building itself was owned by somebody else, and the Eastern Cape Department of Health had to pay 8,500 Rand a month in rent. And suddenly at the end of 2012, the department decided that it didn't want to pay that rent anymore. And so it moved the facility starting from the 1st of January into a field. A marquee was provided by the local hospital, and there was this park home that was provided for storing of medication. But really what it meant is that people were having to stand outside in the heat and the cold and the rain and the wind, waiting to see a nurse, They were having to describe symptoms in front of everybody around them. They were having to have their children vaccinated using vaccinations that hadn't been kept in a fridge. They were kept in cooler boxes because there was no electricity. The toilets were unsafe. It was a complete disaster situation. So we launched litigation against the Eastern Cape Department of Health and the National Department of Health. And initially, the Eastern Cape Department of Health noted its intention to defend the matter. But then the Minister of Health came in and settled the case, undertaking to build a temporary structure in the short term, and then in the longer term to develop a day hospital for Lusikisiki to make up for the loss of the initial clinic. And I should say that the litigation and that was launched didn't by any stretch come out of nowhere. It started with advocacy by the TAC for a number of months beforehand. They weren't being listened to, and that's the point at which litigation started. So you can see here, this is from the tent clinic. Drugs were being kept in buckets. Horrible toilets were all that was available. And then this was the development of the temporary clinic. There were lots of problems. It took a long time to get to the final permanent structure because there were problems with the tendering, etc., etc. But eventually, they managed to build the Lusikisiki Village Clinic Day Hospital, which is a beautiful building, provides a lot of good services, and is a real asset to the area. In 2014, we worked on a case about the SANDF's discrimination against people living with HIV. This had been a long, ongoing problem, and there had been a previous case in which the SANDF was told that it wasn't allowed to discriminate against people living with HIV, but it was still doing so. It was refusing to recruit, to send into the field, and to promote people living with HIV, and that was contrary to its own policies. And those policies have been developed in response to earlier litigation. And so we worked with a union and or two unions and some individuals who had been affected by this in litigation against the SANDF. And were successful in that case. The judge said, if the government becomes a lawbreaker, it breeds contempt for the law. It invites every man to become a law unto itself. It invites anarchy. And then the most recent case that we're working on now is a criminal case. It's about, again, a member of the SANDF who has been accused of having knowingly transmitted HIV to his partner. And in this case, we are seeking a way to intervene on behalf of the Treatment Action Campaign because the science has shown that, firstly, we need to treat HIV as a public health matter, not a criminal matter, and that HIV is no longer a death sentence, and that it shouldn't be singled out as a disease, the transmission of which is a criminal offense. So there's no crime of HIV transmission in South Africa, and that's what this map shows. We're blue, which means that it's not criminalized, but however, you can be charged under normal criminal law. So this man's being charged with attempted murder, alternatively rape, and so we're seeking intervention in that case. So this really is just a kind of smattering of some of the cases that we've been involved in, both particular in relation to access to healthcare services and non-discrimination for people living with HIV, and more broadly in recognition that the health system and reform of the health system impacts directly people living with HIV and their access to services. So here are some of the lessons that we've learned and continue learning. Partnerships are the most important thing. We never do any of this work by ourselves. We're always working with activists directly in the field with direct experience and direct access to decision makers at low level, at kind of local government level, all the way up. It's important that we're not seeing this as a kind of academic and rights-based only issue, that we're seeing it, that we're working with affected people to make sure that the solutions that we're seeking are the solutions that they need. We also work a lot with the media and make sure that we're linking any litigation work with advocacy work, and that's important, as we all know, leading up into a case, but more important than that for monitoring and ensuring compliance with cases. And our work with the media is particularly important because it's what can kind of catch the public imagination. And then the last thing is just that big change takes big time. You know, the individual cases can be won and can achieve relief for individuals, but to really shift the big system, it takes a lot of time and kind of cumulative effort and work with partners. And I think that's the thing that's most difficult and frustrating, but that we've really got to remember in trying to do any of this kind of work on access to healthcare services. It's a big challenge that we're trying to overcome. Thanks very much.
Thanks so much, Sasha, for that. Just to our participants, there will be a Q&A section afterwards. So if you would like to ask a question, you can just put it in the chat section. I'm sure there's going to be a lot of questions after Sasha's presentation. Now I'll be handing over to Professor Naima Abrahams. She's a unit director at the South African Medical Research Council. And the Medical Research Council has recently released new research which deals with the risk of victims of rape in contracting HIV/AIDS. And this is actually a global first as far as I understand. So Professor Abrahams will be touching on that and a bit more of the other work that the MRC has been doing. Professor Abrahams, if I can hand over to you.
Yes, good morning. Thank you very much for inviting me to do this presentation. I'm going to try and share the screen, which I have done just now, but it's not popping up. I don't know why. I can't find. Let me try once more. Sorry about that. If not, then I might have to ask one of you to share it for me. It's because I'm using more than one screen.
Naima, shall I try? Because it's clearly...
It's because I'm using multiple screens. Let me try just once more. If not, then you go ahead, right?
Okay.
Right. There we go. Tell me if you can see it. Can you see the screen? Can you see the presentation?
Yes. Yes, we can.
Okay. All right. Okay. Okay. Let me go. Okay. Like I said, thank you very much. We're going to shift gear. I found Sasha's work, the importance of doing research for advocacy so important, and it really kind of makes the work that we do really important. I'm briefly just going to tell you about our unit. I'm not going to read out this the slide, but just to tell you the broad kind of work that we do on gender-based violence, with a big focus on the health burden associated with gender-based violence. We've been working for more than 25 years, and although our focus has been on gender-based violence, we have moved also into sexual and reproductive health and HIV in particular as well. So I'll start off by just setting the scene. There's been new prevalence estimates from the global study of estimates, but generally it hasn't changed. About 1 in 3 women experience intimate partner violence across the globe. This really is dependent on how, based on good research, population-based data, and we all know it's not easy to do gender-based violence research because not all women is prepared to disclose that they are the victim or they're perpetrating when we do it. But the African region has amongst the highest, going closer towards 40%. I just thought I will pull up the slide just to tell you about what rape reporting looks like in the country in the last 10 years. This is rapes reported to police. We know from other work that we've done that 1 in 25 women who reported a rape in a study with us said they also reported a rape to the police. So that gives you an idea of the huge underreporting that's happening around rape. Then just I want to just remind people that the levels of violence in our country, this is work that we've done in Gauteng a while ago. It's a population-based study, so it's representative of the Gauteng population. We spoke to men about their perpetration, we spoke to women about their experiences, and invariably you will see that psychological abuse is the most common form perpetrated and experienced as well. So this talk really is about violence against, about HIV in particular, and violence against women. So we know a little bit about it already. We know that in South Africa, we did a study many years ago where we looked at a woman that were attending HIV antenatal clinics, and we saw that women with HIV were more likely to also have a history of intimate partner violence and reporting having a partner that were showing controlling behavior. We also later in a study in Tata from the Eastern Cape showed that physical and sexual intimate partner violence was associated with the increased risk of HIV. We also know that men who rape have more risky sexual behaviors, they have more sexual partners, they're more likely to have transactional sexual sex, they are more physically violent, and they also consume and abuse alcohol more. So given this, we and because of, I was involved in work where we were trying to estimate the burden of intimate partner violence and rape. And we wouldn't include, or rape and intimate partner violence was excluded because there was no evidence that intimate partner violence and rape actually impacts on the health. Now we know that is total nonsense. We know in the clinical settings women enters, we know clinicians will tell us the PTSD and the depressions they see. But those were clinical data. There were no longitudinal data to show that rape happens at this point and the health appears later. So this is when we started a study, and we called it the RICE study, the Rape Impact Study. It was a longitudinal study. It was based in Durban. And this study, we used rape, so it's penetrative rape. We didn't look at other forms of sexual violence, and we followed rape as defined in the law. And what we did was we wanted to look not just at HIV in the RICE study acquisition, we also wanted to look at the other health burdens, mental health in particular. We also wanted to look at other HIV risk factors, and we also included other biological markers such as hypertension, diabetes. What we realized also was that the current post-rape care, as we see it today and as it is experienced, there is a focus on HIV, but it is about the immediate exposure, assuming that the perpetrator was HIV positive. PEP would be given to women as part of the management of preventing HIV as a result of the rape event. So we wanted to look at HIV acquisition over the period after the rape. And we followed women up for a minimum of 12 months. and we compared them with a group of women who had not been raped. So we had a control group. We had a group of women who we recruited at the Tutuzela Care Centers, TCCs. This was based in Durban only. And it was very important that the first interview had to happen within 20 days of the rape event. And this was so that we could test for the HIV, first of all, and that we could assess their mental health. And for example, PTSD is very closely linked to when the trauma event happened. So we had to assess that. We excluded women, and so it was only women. It was women 16 to 40 years old. And we enrolled them into the study. The control group were women who we screened for rape. And they were not included if they had ever had a rape, exposed to rape. We recruited them from primary healthcare clinics, quite close to the TCCs, and we did this because we know that the women in our rape cohort were women that went and sought a service. And we wanted to have a similar control group who were using health services as well. And that's why we didn't take women from the general population. So broadly, the study started in October 2014. We ended on the eve of the hard lockdown on the 26th of March last year. And we were able to follow women up. For some women who entered the study quite early in 2014, 2015, we could follow them up for a longer period. But those that entered the study in 2019, we were able to follow them up only for 12 months. We did interviews every 3 months in the first year, and thereafter we did interviews every 6 months. They came back to the Rice Clinic. We did face-to-face interviews. We were very cognizant of trauma that's associated with rape. We made sure that all our field workers were very sensitive and trained around engaging with rape survivors. We had a trauma counselor that were part of the team and would do immediate assistance. And our staff itself also, we had to make sure that vicarious trauma wasn't, we were very cognizant that it could affect them as well. So we measured, importantly, was HIV and range of social behavioral factors, mental health and sexual and reproductive health as well. So here is the enrollment into the RICE study. The purple bits are the women that were recruited at the TCCs, and the orange is the women that were recruited from the primary healthcare services. You will see that obviously participants screened out, for example, baseline interviews, 1,799 women we were able to enroll, of which slightly about, there was 100 more in the control group, 947. We tested them for HIV. So, oh yes, what I forgot to mention, we included women who tested positive as well, because one of the other aims of our study was to look at how a rape impact on women's HIV immunity, HIV positive women's immunity. We wanted to see whether it affected the staying in care. These are all analysis that we're still going to do. We've not quite gotten there yet. So in the end, we had just over 1,000 HIV negative women whom we could follow up for a minimum of 12 months to determine the whether they seroconverted to HIV. We had a larger number of women on loss to follow up among the rape exposed. That was, we accepted that because women had real difficult time in the period immediately after the rape. So of the 1,019 women, we did analysis. We calculated the HIV incidence in each group. We did a couple of modeling that the statisticians largely helped me to do. And it was very important that we control for factors that could lead to HIV acquisition, right? We looked at past trauma and we controlled for that in the model. We looked at loss to follow up, and we looked at sexual risk behavior between visits as well. So, and we considered that as a time varying variable that could impact on HIV acquisition in the period, and we control for that. So this is basically just a social demographic. I wanted to just show you there were differences between the two groups as far as the baseline social demographics are concerned. The main one was we found that women who were raped were more likely to report that they were employed. And converse to that, and as expected, the women who were the control group of women were more likely to report that they depend on the child support grant. And we believe this is very likely because these are the women that were attending primary healthcare services. They were not working. They were depending on, they might have been seeking for work, and that is why we see this difference between the two groups. We control for this in our model. So the main finding, we had 86 women seroconverting in the period, and we did see a difference between the two groups. We found an incident rate amongst the rape-exposed women that was 6.6 per 100 person years, and it was 4.7 amongst the women who did not, who were the control group. I'm talking to a group of people who knows the HIV sector and data much better than me. But as far as we could establish, the HIV incidence between the 15 to 24 years is usually sits below 2. So what did this mean in terms of looking at it over time? What is happening over time? And this is a really useful way of looking at it. So I'm comparing the control group, who is the orange line, and the purple line is the woman that reported a rape at baseline. And this is the follow-up period, and we're looking at incidence. And you can see the incidence amongst the rape exposed over time. It was very similar at 3 months, right? The incidence between the two groups was similar. Something happens to the rape exposed woman over time from about 6 months onwards. And we think the most likely change that is happening is because of we think mental health interferes, and which interferes with the ability to protect themselves. So we found there was a 60% greater likelihood to acquire HIV amongst the women that reported a rape compared to the control group. Like I explained before, we control for all these characteristics that might have impacted on the HIV acquisition over time. And despite that, we find a significant difference with a 60% increase. This next slide, we try and explain how the role of mental health affected the woman. So what I have here on the horizontal side, we have the time. So it's baseline 3 months and 6 months. And on the vertical axis, we have depression. And depression is divided into 4 into four quanta. Sorry, it's PTSD that is on this axis here. So this is the score for PTSD, and the score for PTSD cutoff is 40. So if you score above 40, it means you have you're positive for post-traumatic stress syndrome. At the same time, I've got 4 lines that depicts depression. And this red line is the women that are reported the most depression. And this line here is the woman with the least depression. So what we see here is depression and PTSD goes together. That is well described in the literature. High depression is associated with high PTSD. And we see at baseline it is high. And we see over the period at 3 months, the women that are most depressed are also most likely to also experience PTSD. And we see it declining very slowly. In fact, at 6 months, 25% of the women who were raped had PTSD. So how do we explain, we try and explain what is happening to women in the period after rape. And so I'll just briefly go through this diagram, which we try and use to try and understand what happens in a very simplistic way. I know there's a lot more complex things that's happening in the background, but just imagine a rape happens, right? The rapist is either he is HIV positive, he's not on ARV. This increases the woman's very high likelihood of getting HIV at the time of the rape. Right. If the green bits are the ones which are protective, the orange are the ones that are increases the risk. If this woman took her PEP to completion, if she have social support, if she's able to get access to information, she is very likely not to acquire HIV. However, if for the immediate rape, all of the other factors which also impacts, if we imagine the woman is raped, she's raped by somebody who's actually negative, or he's HIV positive, but is virally suppressed, she's unlikely to get HIV immediately. But something happens over this period. And these are the factors, which is the mental health factors, stigma of rape, in particular stigma of taking PEP, which is the stigma attached to HIV, or impacts on her ability to protect herself and to be able to not engage in HIV risk behavior, which leads to HIV infection. I'm aware this is a very simplistic way, but it is a way for us to understand the importance of mental health in this period, the importance of support. And it now talks about the importance of maybe PrEP as well. So in conclusion, the study has shown us there is the risk for direct HIV at the time of the rape event is not really the problem for us if women take PEP. The problem is in the period afterwards. And it's about the period afterwards where the women are getting the support and they stay in the health system and they get the mental health and that they require. Very often women is kept in the system just for 3 months. We give basic trauma counseling, which is really just containment. We're not providing the mental care that is based on evidence, based on trauma-focused intervention, and this is what is required, and that is entirely missing, and that we're failing women. I think I have said this, that we need to treat the psychological trauma, but I think an area that we need to think about PrEP is it's been taken up. It's supposed to be universally available to young women or at-risk people. Are rape survivors also at risk? Should we be considering how we give them PrEP? I know that some of them struggle just with PEP, but PrEP is really the same thing. It's just an extension of PEP. So we need to understand, how do we support rape survivors in taking PrEP, and how do we combine PrEP and mental health as part of the critical care that's required. That's the end of my presentation. This has been written up in a peer-reviewed paper as well as in a research brief. Thank you very much.
Thanks, Prof. Abrahams. Now we're going to open up for some questions. So please use the chat option, and then we'll take the questions from there. Okay, so I've got the first question then, if no one's going to come forward. Now this is to both Prof. Abrahams and to Sasha. It's just with regards to the research where you say that 60% of women have a greater likelihood of contracting HIV if they have been raped. How does that link up with the sort of global initiative to decriminalize the transmission of HIV/AIDS? So how do you see the research that you've just conducted, and whether it could perhaps be hampered by these decriminalization initiatives?
That's directed to me. Yeah.
Yes, to both you and Sasha.
So, yeah, Sasha, can I go first? I'm not sure if I have the entire answer. So, I don't think it affects the decriminalization of HIV is something that must happen. There's no doubt about it. This is about providing the care that's needed for rape survivors, things that we have not done well enough. I know that the NPA thought that they could use this in cases where rape happens, and they could use this to, I think, in the aggravating of sentencing, where they could say, this rapist, this person raped this person. There is a very strong likelihood that this woman could acquire HIV because of the rape and the impact of the rape. And I think that's useful, and I think that's a possibility. The rape happened, and the rapist was not necessarily HIV positive. So I think that's where the discussion needs to be, and the debate needs to be, and we need to understand. I don't know if I answered that question, but it raises a lot more questions for me to think about and to discuss with people, I think.
No, I think it's a very difficult issue to address. Sorry, Sasha, I'll hand over to you now.
It is a difficult issue to address. Thanks, Chantal. I think, yeah, I mean, as Naima says, HIV can be considered an aggravating circumstance in sentencing. But I think the first thing to say is that people can still be charged with rape. That they will still be charged with rape if they committed rape, recognizing all the problems in our criminal justice system. But the decriminalization of HIV or not charging people under normal criminal law for transmission of HIV doesn't affect criminal law as it relates to rape. So I think for the reasons Naima gave and many others, it's important that we don't criminalize the transmission of HIV, but that we recognize that where there is rape, that in itself is a crime. The problem with criminalization of HIV is that it creates further stigma. It criminalizes transmission of one disease over other diseases. It's very difficult, if not impossible, to prove that if one partner has HIV and the other partner contracts HIV, that it was absolutely that the transmission occurred between those two partners. We need to encourage people to test rather than, and most people who test are women, and so there's a risk that women will be disproportionately affected by the criminalization of HIV, etc., etc. So there are a lot of problems with that I think are actually disjoint from the issues about transmission of HIV during rape or as a result of rape.
Okay. And then just on the issue of the MRC's research regarding mental health, I think that's something that's often overlooked in the discussions around healthcare and HIV/AIDS. Sasha, perhaps you can enlighten us. Has there ever been litigation around the provision of mental health services in this country?
Yes, but not in particular related to HIV. So the mental health needs of people living with HIV, you're right, have largely been under prioritized, and I think there's a real movement from SANAC and elsewhere to start prioritize. So mental health generally has been deprioritized, right? But the particular needs of people living with HIV have not been recognized as much as they should be. We provide, initial counseling when somebody gets a test, and often that's it. And we underestimate the real mental health needs of people living with HIV within the health system. So there's been litigation related to mental health broadly. There was the work on Life is Domeni. There've been other things. There've been improvements to the mental health system, but the particular needs of people living with HIV in relation to mental health have not been focused on as much as they need to be.
Sorry, Prof. Abrams, would you like to add to that at all?
I absolutely agree. Mental health has not received the attention. It's been a big problem because there's not even funding for research for it. So so it's a real struggle for us to really push for this. And so this research is really helpful because we're starting to show the impact of not giving attention to the mental health. The other sad thing about us in South Africa is that we are a country with many people walking with many traumas and the consequences of the traumas. Violence is and the historical trauma as well. And that trauma impacts on our health. And we're not really trauma experts in this country. You often find people, I'm not dismissing, people are doing some great counseling work, but very often the counseling is not trauma-based counseling. We think just listening to somebody and affirming them, which is important, is enough. It's not enough. We need therapeutic care. We need care that focus on dealing with the trauma so that people can move on and their lives can change and their behavior and their the whole stresses attached to it. So it's an area we're very conscious that we need to work on now, and in particularly we're doing an analysis on the counseling, where the counseling impacted on the woman in terms of changing the depression and the PTSD and the stigma and all of that. And it'd be very interesting to see that. But we need to push mental health. We need to support whoever else is trying to make it a problem. We know that there's not enough skilled staff. But even in the Department of Health, you ask, who is the mental health person to talk to? Who do I take this research to? Who will take it up? Who's going to push it? Who's going to be the flag bearer for this issue? And we don't find that person often. Yeah.
Thanks.
Until
I believe that Alice got a question.
Hi. I wanted to ask the professor about the advocacy element of this research and how the MRC works in terms of trying to enlighten the government around these kinds of issues, the Department of Health, the various entities within government. How is this research used to improve policies, to improve engagements and interactions and interventions? Could you just give us a little bit of background on that?
Thanks, Alice. That's an important question. So we are very aware that our research has only got value if it's taken up by policymakers and by advocates. So we launched this on the 1st of December. We had a webinar, and we also adjusted the paper into easy read research brief, which is accessible for people to read and to understand and simplify the research. At our meeting, we engage. We tried very hard we had people from the Department of Health and the NPA, both from the kind of justice sector as well as the health sector, part of it. And we're trying very hard to get people to listen. For example, the whole issue about PrEP for rape survivors now, about mental health for rape survivors. We're knocking on those doors constantly. We don't always get it right. We don't get it right immediately until there is partners and advocates that takes it up for us. As a research council, it's important that our work are taken into policy level. But I can tell you, I know this is a public place, but we work with the Department of Health in developing their rape policy. 8 years ago, we wrote it, we developed it, and it stuck. It never progressed through the Department of Health. And actually we raised it. So when we launched this in December, I wrote an op-ed piece as well, where we asked the question, where is that rape policy? We now need to adjust it even further because of this new evidence. But like I said, the problem is there isn't a person that takes accountable for mental health and for violence against women in the Department of Health, actually. In fact, I mean, we've got a great NSP, right, at the moment, National Strategic Plan. So that's just been launched. It's the government, it's become part of the political agenda. 25 years that I've worked in this area, this is the first time. It is fantastic to have been part of the process. But we really fear that it's going to fall off somewhere. The problem is about leading. Who leads gender-based violence responses in the country? Is it DSD? Is it Justice? Is it the department? Even they struggle with it. Department of Health. So Department of Justice probably is the one department that will take this on. Violence against women, rape, that will take this on. DSD is supposed to be the implementation department, but they give it to NGOs. NGOs who does the work, and they do great work. But it is messy. It's not where we want to be. It's not. I mean, this country haven't ever had a national violence against women study done. There's never been a national. We've done femicide work, yeah, but there's been no national. They depended on the Demographic and Health Survey, and we know that delivers really poor data for South Africa, very, very undercounted. So it does sound like a sad story for us. I'm sorry, but small things help. I mean, coming onto this. Coming and presenting the work here is helpful. I hope those are seen as kind of our advocacy work. I've presented this to NACOSA as well. So I try and find every opportunity to share the work so that we're happy to work with anybody who's prepared to take it up and use the data for advocacy. Thanks.
Thank you, Professor. I'm going to hand over to Amelia now. She's got a question for Sasha.
Thanks, Chantal. Thanks to the panelists for very interesting conversation and very interesting presentations. With less that's being reported on HIV in the last couple of years, one would think that there are no problems. And I think the discussion today actually proves that there's still a lot that needs to be done. And hence we are talking about this today. But I think a quick question to Sasha is that, one of the good strategies about Section 27 and working with the Treatment Action Campaign is actually looking at cases on class actions. And when I was working there as a researcher and a lawyer, what was interesting for me was the walk-ins, and that's how we sifted cases, and that's how we recognized which areas of law we needed to look at in terms of reform and changing things. And I just wanted to check with you, Sasha, how are you, getting these cases? How do you work with communities in relations to getting, maybe individual cases are more, the ones that lead you to class actions, which is what has been the strategy. But I just wanted to check how prevalent are these cases on the ground, and how do you get them to Section 27 in order for you to assess whether there is class actions that need to be, whether you need to take on a case, a class action case.
Yeah, thanks, Amelia. So the walk-ins are still an important source of an important way that we can provide assistance to people and then find out what's going on. So we have an advice office that's staffed by 2 paralegals, supervised by an attorney, and they are the first port of call for anyone coming to Section 27. They will listen to the issue that people present and either refer the case either they'll deal with it themselves. There are many issues that they resolve themselves, many issues that they are able to resolve themselves because they're really excellent. Or they'll refer the case internally if it's a matter that relates to our mandate. So if it's within health education, if it's a case, including a case relating to access to services by PLHIV, they'll refer it internally into the health team. Or they'll refer if it's a case that falls outside of our mandate. So for example, if it's a housing case or a social grants case or anything else, they'll refer it to organizations outside of us, whether that's to people like pro bono or private law firms, or most often to other public interest law organizations who focus on those particular issues. So that's a big way in which we find out what's happening, but we also, as you say, work very closely with TAC across the country. So we have a lot of people contacting us directly from TAC branches. And then we also have field researchers who work in KZN, Limpopo, Mpumalanga, and Eastern Cape. And they work there, they live there, they're in touch with people there. And so information and requests come through there. So that's kind of our general way of people accessing Section 27. And we also try through the media and social media to make ourselves as accessible as possible, although we can never be optimally accessible, because not everyone will find out, and there also aren't enough of us to do everything. But that's generally the way that the cases come through.
And just on that, Sasha, this is the whole aim of this project with probono.org, is to get more attorneys to actually assist on a pro bono basis. And that's why we're running this whole series of webinars to create awareness, but also better equip them. And Amelia's actually drafted a fantastic resource manual to assist lawyers. So for all the participants this morning, I hope you've heard Sasha's call to help. And hopefully we can get a bigger body of lawyers that do this work, because it's just, the cases are endless. We would hope that 25 years of democracy, things would have been better. But I think Sasha's presentation really highlighted the problems. And then just on that, I don't see any other questions. Just on the issue of corruption and healthcare, what do you think that lawyers can actually do? Should they be bringing strategic litigation? Should they be involved in more media campaigns? Because corruption is really eroding every system of South Africa. And it's not something that lawyers are prepared to engage in, either because their clients might be affected, or a lot of lawyers that I speak to just don't know what to do. So what is your advice to them?
So the first thing is that the Special Investigations Unit recognizing that health is a particularly corruption vulnerable sector, started up the Health Sector Anti-Corruption Forum, I think maybe 2 years ago now, which is a forum that includes people from the police and Asset Forfeiture Unit and DOJ and all sorts of, and SIU, obviously, all sorts of stakeholders within government, within law enforcement, and then also people from the Department of Health, civil society in the form of Corruption Watch and Section 27, and a bunch of others to receive corruption in health complaints, to assess them, to investigate them, and then to prosecute them. So that is the part of the SIU that's been working on all of the PPE corruption and other things. I think firstly, it's important to recognize that there are structures that are designed to have this information fed into them, and that as people living in the country, we are able to do that. And so it's important that people don't kind of step back and ignore it. But these issues do arise in the course of much of our work. And I think it's difficult to bring, as a private lawyer, to bring big litigation related to corruption. But this again is where partnerships and using the expertise of organizations and individuals, like Naima and the MRC, like Section 27, like Corruption Watch, and others who have access to different parts of the system and have worked on these kinds of issues. That's why it's important to bring us all together. Because it would be very difficult for a private attorney to bring a case about corruption in health, but there may well be work that has been done elsewhere that can be leveraged off, or that we can work together to push the issue forward. So I would just encourage using the structures that exist, and then also using a partnership model to learn from what's been done before, and make sure that we're using all of the resources we can to push in the same direction.
Thanks, Sasha. During our research for this project, we actually found that a lot of pro bono lawyers would actually prefer working with a network of, whether it's medical doctors, psychologists, psychiatrists, to actually push forward this type of work. So I think, you've touched on that again, and it's really important, and we need to get sort of legal practitioners away from their desks and really reach out to different sectors. Is there any other questions from our participants this morning? Okay, if there's no further questions, then I'm going to hand over to Amelia Motsepe just to give a brief overview of the legal resource manual that she developed for probono.org. It will be available on probono.org's website, and we really encourage everyone to use it. Amelia?
Thanks so much, Chantel. I think I've asked for it to be projected. So I think Marco is doing that. Thank you so much. My name is Amelia Motsepe. I'm the managing consultant of MOT. I was commissioned by probono.org to produce this resource. So MOT is actually a strategy management, operations and project consultancy company. We work mostly with entities that work in the field of human rights and social justice to improve operations and performance and in all aspects of their operations and programs. I have an LLB at Edwards, and I also have an LLM. a master's degree from the United States, and I work a lot with women's human rights and human rights. HIV or public health is actually my expertise and what I'm really passionate about. And thank you so much for Pro Bono trusting me with this really challenging exercise of looking at the law in relation to HIV and TB and how we can best assist people who key and vulnerable population linked to the program that they also have been entrusted to do. So like I said, thank you very much for giving me this opportunity and to do this. As you know, probono.org is tasked to implement part of the human rights plan with the goal of reaching key and vulnerable population. Without saying much and repeating what Alice and the panelists and Teresa or what they've said, but just to say that there are targeted interventions, which includes activities such as legal empowerment, training of paralegals on issues related to HIV, TB, and human rights, legal and paralegal support to community members whose human rights have been violated, including pursuing identified matters to court, sensitization of judiciary lawmakers and traditional leadership, especially those involved in traditional courts. So it is evident from our discussion today and what the panelists have said that issues related to HIV and TB cut across different areas of law, and this poses a unique challenge in navigating through relevant legislation and regulation that protects and promotes those rights. So it is therefore my absolute pleasure. Sorry, this is really exciting for me and hence I'm a bit nervous. It has been a long year with looking at this project and I'm actually feeling a bit emotional just being given an opportunity to launch this. So pardon me with that nervousness, but it is really an absolute pleasure for me to be launching this legal resource titled Reducing Human Rights Related Barriers to HIV and TB Services for Key and Vulnerable Population, a legal resource. As it is pointed there. So just briefly, this legal resource gives practical information on current and evolving legislation, common law and policies pertaining to HIV and TB in South Africa, with the aim of educating, sensitizing, and providing updated information to paralegal and legal practitioners alike who are engaged in offering legal advice and services to individuals and communities who serve members of the vulnerable and key populations that are focused on human rights, on this human rights program. We really hope as a team with Pro Bono and everyone that is involved in the program, including AFSA, that the legal and policy framework that is discussed in this resource will be used to ensure people are educated, to ensure that people are educated and are empowered to assert their rights to equality, dignity, and privacy, especially in the context of access to healthcare, which is what we've been discussing today. In addition, we hope that it will be a reference guide to people who work in the field of health and human rights, for example, training for healthcare workers on human rights and medical ethics, but most importantly, which is what we've discussed a lot today, the sensitization of lawmakers and law enforcement agents to monitor laws and regulation and policies in this area that's contributing to reducing stigma and discrimination and promote access to justice. I think Chantel has already said that this will be disseminated online. It is free of charge, and also it will be, a few copies will be created for perhaps some of the sessions that they will be held face to face. But thank you so much, and thank you so much Pro Bono for giving me this opportunity to do this resource. Thank you.
Thanks so much, and well done, Amelia. If I can hand over now to Alice Brown, that will just close off our webinar today.
Sorry. This is the constant refrain with these webinars. Can you hear me? Are you muted?
Yes,
You're
we
still
can.
muted. This is the language of the day. So I have the pleasure of saying thanks to our panelists. Amelia, I'll work my way from last to first. Amelia, thank you so much for the really hard work that you did on this manual. For our participants, it's about 200 pages long. It includes chapters on every key and vulnerable population, sex workers, women, children, people who use drugs. And for each key and vulnerable population, there is a listing and an analysis of the laws and the policies and the regulations that apply to those particular groups. As has already been said, this is a legal resource for paralegals and legal practitioners, for folk who will hopefully jump on board and do this work. And if they need some quick references to, which law is relevant or which regulation should I be looking at, this is the resource that will provide you with that kind of information. And I want to thank Amelia and the researchers and the like, and the folk who worked on this, but particularly Amelia, who put in a lot of time and energy on this in a difficult year. Thank you to Professor Abrams and Sasha Stevenson for those presentations. Lots of important information, ways in which we need to think and rethink our strategies and our approaches, and the use of data, the use of research, the ways in which it complements litigation and advocacy, and it hopefully will help us think of more interventions, more ways in which we can use that kind of important information presented by the prof, and that important survey study that was done in a way to change for the better policies, laws, regulations, and the like. And based on the professor's response to my question, we know that there are some barriers within various governmental departments that we need to. We've been knocking at these doors for years now, and we will keep knocking at them until we get through and have more of an impact. And Sasha, thank you so much for the work of Section 27 and the impact litigation and the advocacy work that you are involved in and that Section 27 is involved in. It's important work, and yeah, we have to keep on keeping on. I want to say that part of this, this week and this webinar scheduled for this day was in recognition of Human Rights Day, which we all know occurred on March 21st, with the holiday being recognized on the 22nd. I wish I could say, I don't think it's appropriate to say Happy Human Rights Day. I think, we need to look at that date and think about the history of Sharpeville and various human rights violations that have occurred across the centuries, the years, the decades here, and the ways in which we need to not forget and continue to work on continue to work on changing the landscape for the better, dealing with these issues of social justice, equality, promotion of dignity, and the like. So with all of that, I just want to say thank you. And lastly, thank you to Chantel and Marco, who are always fabulous in putting together these webinars and making sure that they happen, and they happen on time, and that the technology is there and the substance is there. So thanks to Chantel and Marco for that. Thank you.
Thank you, Alice. I hope that soon we'll be able to have these events in person and we don't need to worry about muting and unmuting and cameras and whatnot. So just to all our participants, just a reminder that all of these resources will be available on probono.org's website. There is a tab dedicated to HIV/AIDS and TB, and Emilia's resource will be there. There are also a number of YouTube videos that you can access as a quick resource for some issues. And we really hope that perhaps some of your younger legal practitioners will watch them and take an interest. So that's all from our side today. We will be sending you information on more events in future, and please also feel free to get into contact with probono.org if you'd like to get more involved. So thank you very much and enjoy the rest of your day. Bye-bye.